Welcome to chapter 1. In this chapter, we will provide some basics and introduction to nutritional assessment. So, here are our chapter objectives. So, first, we will see the historical evolution of different types of disease in the world and in the US, from chronic disease and infectious disease. And then we will define nutrition screening and nutrition assessment, and we will compare these two concepts with each other. And then we will understand the different methods for conducting nutrition assessment. Then we will talk about nutrition care process, and we will define what nutrition care process is and what are the different components of this process. And finally, we will learn the, the key role of nutrition assessment in the prevention and treatment of chronic disease. So, as an introduction, as I said, this chapter is all about kind of introduction to nutrition assessment and nutrition care process in general and the components of that process. So, but before defining nutrition assessment and nutrition screening, first we need to know about some terms and some concepts, and we are going to define them here in few slides, and then we will dive deeper into nutrition assessment itself. So, nutritional imbalances, when we say nutritional imbalances, it means like there are some deviations from optimal nutrition. And that nutrition imbalances or the deviation from optimal nutrition can cause some problems. And that problem can lead to a significant increase in the risk of mortality and morbidity. So, mortality is related to death, and morbidity is related to disease or like health conditions. And nutritional imbalances is a severe public health problem worldwide and in the US particularly. And regarding the nutritional status, we hear nutritional status so often when we are reading textbooks or on social media. So it's better to understand this key concept here. So when we say nutritional status, first we need to know that different nutrients and diet can affect nutritional status, which refer to as the state of our overall health and body status. That is nutritional status. And there are several factors affecting our nutritional status, from consuming food in sufficient amounts to different types of diseases, environmental factors, behavioral factors, they all can affect nutritional status. But in the textbook, it just it listed just the diet and nutrition related factors like when we are selecting the right foods for our body, we are optimizing our nutrition status. We are improving our nutrition status by choosing the right foods for our body, by following a healthy eating pattern. We are helping our nutritional status. But overall, when we say nutritional status, just remember it. It's the state of an individual's overall health and body, which is influenced by levels of nutrients and diet. This chapter also defines malnutrition. If you read the textbook, you will see different definitions for nutrition screening, for nutrition assessment, for malnutrition. So we don't want to stick to just one definition. So we are gonna use all, and we will see the similarities between different definitions. And why do we have different definitions for a concept like malnutrition? So that's a good question. So different organizations they provide their own definitions for different conditions like malnutrition, or they define key nutrition related concepts like nutritional assessment. So that's the main reason we see different definitions. So the definitions varies by organization. So malnutrition is one of them. But for an introduction to malnutrition, malnutrition is a condition and from undernutrition to overnutrition. So undernutrition is nutrient deficiencies, and overnutrition can be caused by like consuming an extreme amount of calories or nutrients. Overweight and obesity is a type of malnutrition. So, for example, a person can be overweight or obese from caloric overnutrition and at the same time be deficient in other macronutrients or micronutrients. So, and when we say macronutrients, uh, we refer to carbohydrates, proteins, and fats. And when we say micronutrients, we refer to vitamins and minerals in general. According to Aspen, American Society for Parenteral and Enteral Nutrition, we can identify and detect malnutrition if we see two of the following symptoms. So, out of these listed symptoms, if we find two of these symptoms, we can say that that person or that individual is malnourished. So these symptoms are inadequate energy intake, weight loss, loss of muscle mass, loss of subcutaneous fat. Subcutaneous fat, we can divide our body fat tissue into two main groups: brown fat tissue and white fat tissue. The white fat tissue, we can find white fat tissue around main organs, which is also known as visceral body fat, and under skin, it is called subcutaneous fat. So loss of subcutaneous fat or loss of the fat under the skin can be a symptom or sign of malnutrition. Localized or generalized accumulation of fluid, which also known as edema, and decreased functional status measured by hand grip strength. The last symptom is mostly seen in the elderly or among older adults. This table is from your textbook and shows like different body systems from skin to hair, eyes, muscles, bones, and it shows the main sign and symptoms for nutrient deficiencies. This table can also be a question if you want to like take the RD exam, registered dietitian exam. This table can be a question on your exam. So, for example, they say like, what's the main nutrient deficiency in impaired night vision? That can be vitamin A. Or like, what nutrients can cause rash in the skin? Like zinc or fatty acids, essential fatty acids. If we are deficient in zinc and essential fatty acids and some other vitamins, we can develop rash in the skin. The key point here is malnutrition is not prevalent solely in underdeveloped countries. We can see malnutrition in developed countries as well, like the United States. And as I said, uh, it can increase the risk for morbidity and mortality. Mortality is death, morbidity is like different disease, like hypertension, heart disease, diabetes, stroke, and cancer. Malnutrition can cause them. Among children, malnutrition can cause poor quality of life, low birth weight, disability, and also among older adults as well. Like disability is like decreased function. Poor quality of life is a complication of malnutrition in both adults and children. According to the literature, in the past, the prevalence of chronic diseases related to nutrient deficiencies was a major problem in the United States. So we can develop some chronic diseases stem from micronutrient or macronutrient deficiencies. And that chronic diseases were more prevalent in the past in the US, which is totally correlated with specific nutrient, especially micronutrient or undernutrition deficiencies like vitamin C deficiency, vitamin A deficiency, iron deficiencies. These were prevalent in the US. This is another term, nutritional epidemiology. This is a new field of research which examines the association and relationship between nutrition and diseases. That's called nutritional epidemiology. And we will see that in next chapter. So after that, as we mentioned in the past, nutrient deficiencies were prevalent in the US. But after that, the American government mandated food enrichment and fortification for a variety of staple foods. So they fortified rice with vitamin A and iron, or they fortified wheat and grains with some micronutrients. And after that, the result was significant. So chronic diseases related to nutrient deficiencies rates decreased. And nowadays, nutrient-related chronic diseases are no longer a major health problem in the US. But today we see other problems. We see overnutrition related chronic diseases these days, like overweight, obesity, and its complications like hypertension, type 2 diabetes, different types of cancers, heart diseases, stroke, and so on and so forth. There will be a table we will see in a few slides, and it lists the most top 10 leading causes of death in the US. Among those 10 leading causes of death, four of them are linked to the diet, which means we can manage those conditions, we can prevent those conditions or delay those conditions by changing and modifying our uh, eating pattern and making positive lifestyle changes. So among those, again, 10 leading causes of death in the US, four of them are very important: diabetes, overweight, obesity, heart disease, and cancer. And we see so many papers published in different journals examining the relationship between these disease and diet and exercise. So this slide is about obesity prevalence. You don't need to memorize and remember these numbers, but it's good to know because these numbers are huge and it is worth mentioning it here. So in the US, unfortunately, and this is a very great prevalence, almost approximately 50% of the adult population are obese in the US. One third of children and youth are overweight or obese in the US. And these rates, these high rates causes a significant substantial increase in healthcare costs, in medical costs. And it can cause other complications, other health problems. As I said, obesity and overweight is highly correlated with the prevalence and the development of type 2 diabetes, cancer, heart disease, and etc. And this map shows the rates of obesity by states. So as you can see and as you can imagine, most of the southern states are are more prevalent in obesity rates. So we can see Arkansas, Louisiana, Mississippi, Alabama, Tennessee, Missouri, Oklahoma, Kansas, and Texas, and Iowa. These are these are among the, the states with high prevalence of obesity. So nutritional assessment and malnutrition. As I said, if you read the textbook, you will come across different definitions of nutritional assessment, nutritional screening, and malnutrition. So here, I try to mention all in PowerPoint slides, uh, but you will find some similarities between deficiencies. So when we say nutritional assessment, it's a structured way. It's kind of a systematic way or a framework uh, to establish nutritional status and energy requirements. And there are different methods for data collection for nutritional assessment, and we will see that in a few slides. So the main purpose is to find any nutritional related problems and etiology for different diseases by conducting nutritional assessment. And malnutrition, again, we already defined malnutrition, but here we have another definition. Malnutrition is an acute, subacute, or chronic state of nutrition. Subacute is a is a phase between acute and chronic condition. So malnutrition, again, it's a wide spectrum from undernutrition to overnutrition, with or without inflammatory activity, which which results in a substantial change in body composition and diminished function measured by, for example, hand grip strength. There are other types of measures for measuring function, but the most reliable way of measuring function is through hand grip strength. So malnutrition can cause changes in body composition. Like this is exactly what we saw in the previous slides. Loss of muscle mass, loss of subcutaneous fat, these are body composition. So malnutrition can cause changes in muscle mass and body fat tissue. And as I said, malnutrition either undernutrition or overnutrition. They are all prevalent in underdeveloped as well as developed countries like the United States. And approximately around 870 million adults and children globally have inadequate food intakes. Again, this is a very high rates, unfortunately. This figure is from your textbook, and this figure depicts a historical perspective. So, like here, starting mid 1700s, James Lind was a researcher who found scurvy, which is vitamin C deficiency disease. And from mid 1700s to 2012 and future, it's going on. It's an ongoing process. We see different time points in which different types of diseases were identified and examined and researched. But again, if you can see, most of the time, for example, let's say before 1974, we see nutrient deficiencies, but after that, we see like chronic conditions related to overnutrition, not undernutrition. In the United States, we have different health programs and health promotion programs established by the American government, uh, which addresses the chronic diseases related to overnutrition and undernutrition, actually. So, for example, Healthy People 2020. This is a government funded health promotion program. And I also provided the link for you if you want to like dig deeper. Uh, Feel free to do so and learn more about this health program. So this is a disease prevention program. It has a set of goals and objectives in the whole population in the US. So it's a nationwide program that's not just local or locally funded programs or statewide programs. It's a nationwide program. And it has a set of goals and objectives. Most of the time, it is a 10-year targets. For example, one of the goals in Healthy People 2020 was to reduce the proportion of adults who are obese by 2030. So starting 2020, they have a 10-year target for several goals and objectives. And one of the goals was to reduce the proportion of adults who are obese in the United States. And these programs are really crucial. They are funded by the government. They are implemented by the government and then by the states, and they gather data to see where they fall short, and then they can fund more those areas in the future to prevent those like conditions or health problems. So leading causes of death and chronic disease. As I mentioned, there is a table lists top 10 leading causes of death in the US, and four of the 10 leading causes can be prevented or delayed by modifying our diet, by following healthy eating patterns, and changing our lifestyle. Um, and we will see that table thing in the next slide. So as I said, by modifying diet and by choosing, like healthy lifestyle, we can prevent or delay those chronic conditions. So, four of these top 10 leading causes of death are heart disease, cancer, stroke, and diabetes. Can be either prevented or delayed by modifying diet and implementing positive lifestyle choices. So, as you can see, heart disease is the number one. It's the number one leading cause of death in the US. The second is cancer. The third is respiratory diseases. And if you can go, we have diabetes, which is the seventh leading cause of death in the US. And then we have influenza, and suicide is the last one. In 1974, Dr. Charles Butterworth wrote a landmark paper, The Skeleton in the Hospital Closet. So, the skeleton in the hospital closet refers to malnutrition, refers to undernutrition, malnutrition due to nutrient deficiencies. It happened in 1974. And then later in 1995, the Joint Commission, which is a US nonprofit healthcare accrediting organization, worked with some inputs from different other organizations like the American Society of Clinical Nutrition and the Academy of Nutrition and Dietetics. They developed nutrition screening framework and guideline. And according to the Joint Commission, every institution and every facility must conduct nutrition screening from each patient within 24 hours of admission. Again, this can be a question on the RD exam. So each institution must conduct nutritional screening. We have different tools for nutritional screening, and these tools vary by facilities, by the institutions. So nutrition screening is a standard framework used by hospitals and other clinical settings that can be a long-term care facility or children hospitals or etc. And then they conduct nutrition screening for each patient admitted within 24 hours to the hospital. We use nutrition screening for early detection or identification of malnutrition. Again, as I said, we have different tools, and these tools vary by the institution and facilities. But the goal is the same, to identify and to detect malnutrition. So in the past, and some institutions these days use albumin as the primary indicator to identify malnutrition, but there are some limitations for that. Albumin, as you know, is a protein in the blood produced by the liver, and this protein carries different nutrients in the blood, like calcium. Calcium binds with albumin in the blood. But this is a poor diagnostic indicator. Why? Because it is influenced by different factors, especially external factors such as trauma, surgery, or inflammatory diseases. If you heard the term, uh, there are some proteins in the body like albumin and transferrin. These proteins respond to inflammation, to stress, to surgery, to trauma, to infections, and their levels change by different conditions, by external factors. So these proteins, these biomarkers cannot be reliable. So that's why albumin is a poor diagnostic indicator. But unfortunately, I have seen some institutions and facilities still use albumin as the primary indicator for malnutrition, and they use it in their nutritional screening forms. But these days, Aspen American Society for Parenteral and Enteral Nutrition and the European Society for Clinical Nutrition and Metabolism, they developed an etiology-based approach to diagnose adult malnutrition. Nutrition screening is the first line process of identifying patients who are already malnourished or at risk of becoming so. And according to the Academy of Nutrition and Dietetics, we need to use nutrition screening to identify individuals who are at nutritional risk. And if we find a person, a client, or a patient who are at risk, we should give them a high priority for a thorough nutritional evaluation, or in other terms, nutritional assessment by a registered dietitian or by an registered dietitian nutritionist. Again, as I said, just like nutritional assessment and malnutrition, we have different definitions for nutritional screening. So if we want to define nutritional screening, we can define it as the process or a framework or a structured way of identifying patients, clients, or groups. Groups is very important here. We can apply nutritional screening to community, to the population, not only to individuals, not only to patients. We can we can conduct nutritional screening in the community-based settings, like in health fairs or or other community meetings or whatever, or community events. We can conduct nutritional screening. So it's a nutrition screening is a process of detecting and identifying patients, clients, or groups who may have a nutrition diagnosis and benefit from nutritional assessment and intervention by an RDN. So in hospital or in clinical setting, within 24 hours of admission, they conduct nutrition screening. And nutrition screening can be conducted by an RDN, by a dietitian, or by other healthcare professionals, like by nurses or other people who are trained to do so. And after, if they identify a problem, if they identify that this patient or client is malnourished or is at risk of becoming so, then they can refer that patient to a dietitian, and that dietitian can conduct nutritional assessment. So we have different tools, but all of those tools should be quick, easy to use, and completed by any member of a healthcare team with minimal nutrition expertise, such as diet technicians, nurses, and physician assistants. These tools should be validated. In other terms, they should have high sensitivity and high specificity. The difference between sensitivity and specificity is this. So when we say a tool or a measurement is high sensitive, it means that it can detect and identify those patients or those clients who are ill or sick accurately. that is high sensitivity. Specificity means to accurately detect healthy people or healthy client who doesn't have the condition. That is high specificity. So screening tools, nutritional screening tools should should both have high sensitivity and high specificity. And as I said, screening forms can be used in both community and clinical setting. And when we say like community setting, we can use nutritional screening forms to identify risk for different chronic conditions like diabetes, heart disease, and hypertension in adults. Screening forms offer to the elderly living in the community setting or assisted living to identify risks for malnutrition, osteoporosis, and other chronic diseases. And the criteria on the screening form varies by facility. So we have different tools for nutrition screening, and we have different criteria for nutrition screening. So at the table on the right side of the slide, you see nutrition screening key criteria. So some forms use BMI, some forms use appetite, some forms use albumin, some forms use diminished function. Uh, for some nutritional screening, they measure hand grip strength, but for some they do not measure function. So those criteria uh, varies by facility. But commonly used risk assessment parameters are recent weight loss, recent poor intake or appetite, and BMI. These three parameters are commonly used risk assessment in nutrition screening forms. Again, we have some numbers here. You don't need to memorize or remember them, but it's good to know. 30 to 50% of adult American hospital patients are malnourished. This is estimated. So we don't have exact number, but based on the estimates, this is a high rates again, just like the rates of obesity and the rates of chronic diseases in the US. Again, this is a high rate. And these numbers are in the US. So pay a close attention to these terms, to these statements. And few patients actually receive a formal malnutrition diagnosis, only 3.2%. And, as we said, malnutrition can cause a significant increase in morbidity and mortality, increased length of hospital stays, increased rates of hospital readmission, and decreased function and quality of life. And this table summarizes some, commonly used nutritional screening tools. So we have malnutrition screening tool, which is used in acute care hospitalized adults, oncology patients. We have mini nutritional assessment, MNA, which is a short form, and it is used in subacute and in the long-term care facilities. We have malnutrition universal screening tool, also known as MUST, and we have nutrition risk screening, NRS 2002. So if you look at the risk screening parameters, you will see the differences. So like recent weight loss is among all of them. But for example, we have mobility only in the mini nutritional assessment. So mobility is a key risk parameter here because it is used in subacute and long-term care facilities, which are older adults. The patients are mostly older adults, and they have different ways of measuring malnutrition risk. So they assign different scores for each question, and then they sum the scores based on the total score. We can identify malnutrition, or we can identify patients who are at risk for malnutrition. So far we learned about nutritional assessment and nutrition screening. So as a summary, if we want to compare screening with assessment, so we can say nutrition screening identifies the risk for a nutrition problem or malnutrition. However, nutritional assessment identifies the presence or a diagnosis of a nutrition problem or malnutrition. So the difference is the risk and the presence or diagnosis here. And just like nutritional screening, we have different tools for nutritional assessment, but those tools should be also validated and be used by RDNs or other trained healthcare professionals. Most of the time, nutritional assessment is conducted by dietitians in hospitals and other clinical settings, but nutrition screening can be done by nurses, dietitian technicians, or physician assistants, or other uh, healthcare team members. The subjective global assessment, abbreviated as SGA, this is one of the well-known nutritional assessment tool, and it is a validated tool. Initially, it used as a screening tool, but right now we are using SGA as a nutritional assessment tool, and it measures nutritional status or nutritional assessment based on weight change, dietary intake change, ankle edema, citis. Citis is the edema um, in the belly area. That's called ascites, and it occurs due to either liver failure or um, mostly liver failure can cause ascites, which is a accumulation of fluid uh, in the center of the body. So we conduct nutritional assessment after an individual is referred. Again, as I mentioned, when a client or patient is admitted to the hospital or an acute care hospital, healthcare members or dietitians, they need to conduct nutrition screening. And if they identify a problem, or they identify the patient is malnourished or is at risk for malnutrition, then they refer the patients to dietitians. And then we conduct nutritional assessment. Nutritional assessment is the first step to identify deficiencies and nutrition related problems. And those deficiencies and nutrition related problems can lead to chronic diseases or malnutrition. Nutritional assessment is not just a step and then we move on to next step. It's a dynamic, it's an ongoing uh, and non-linear procedure. And according to the Academy of Nutrition and Dietetics, Nutritional assessment is defined as a method of identifying and evaluating data needed to make decisions about a nutrition related problem or diagnosis. These are the main four dimensions of nutritional assessment. Some textbooks uh, they define five dimensions for nutritional assessment, but this textbook defines four, and it's called ABCDs of nutritional assessment. A stands for anthropometry, B stands for biochemical, C stands for clinical, and D stands for dietary assessment. And then, later throughout this course, we will dive deeper into these each dimensions of nutritional assessment. But here in this chapter, as an introduction, we will go over them quickly. So when we say anthropometry, it's the study of the measurement of the human body, like bone, muscle, and adipose tissue, or body composition. It can include body weight, height, BMI, waist circumference, head, chest, and neck circumference, skin fold thicknesses, which measures subcutaneous fat. We have limb length, and we have like other measures. But BMI is one of the well-known and most commonly used anthropometric data. And anthropometric data is a non-invasive uh, way of measuring human body components. Because measuring weight or measuring height is of course non-invasive. And as you can know, BMI, this is the BMI formula, body weight in kilograms divided by height in meters squared. If we have body weight in pounds and height in inches, we have to multiply this fraction by 703. So remember that. Again, that can be a question on the RD exam. So if we have body weight in pounds rather than kilograms and height in inches rather than meters, we can divide body weight in pounds by height in inches squared multiplied by 703. So if BMI is less than 18.5, it's underweight. Between 18.5 and 24.9 is normal, and we go to overweight, and then classes of obesity, which has three classes. So as I mentioned, malnutrition is kind of a wide spectrum from undernutrition, which is due to nutrient deficiencies, to overnutrition, which is due to caloric overnutrition or macronutrient overnutrition, and in the middle, in the center, we have optimal nutrition. Regarding the biochemical data, in our blood, we have some chemical substances which are influenced by the diet and the nutrients we consume and intake. And if we measure those chemical substances, they can reflect the person's diet composition and quantity. But for like there are some other chemical substances which are highly maintained by our body system, and we cannot like change those like chemical substances or nutrients by diet or by nutrition. So in other words, we cannot measure biochemical data for nutrition assessment solely. So it's not a standalone indicator for a nutrition related problems. So when we say biochemical data, it's the concentration of chemical substances in tissue and body fluids. It can be this can be like uh, the chemical substances from blood or from urine samples and some other body fluids like saliva and also tissue. And we can measure them and they can reflect a person's diet's composition and quantity. Um, but again, these are not reliable as standalone assessment tools. And these can be influenced by external factors like medications, hydration status, state, and stress. Just like albumin or transferrin. Transferrin is a protein, carries iron in the blood, and it can be influenced by stress or by other external factors. So here, let me give you an example for the hydration status. So if we measure blood sodium levels, it is highly influenced by hydration status. So if we are dehydrated, we will see a significant increase in the concentration of sodium in the bloodstream. And if we are overhydrated, we will see a decrease in sodium levels. So blood sodium levels cannot be a marker of sodium intake through diet. So we need to measure other things along with sodium to determine a problem or a condition. So again, these biochemical data are very important and we use them a lot, but we need to take into account other factors when we are interpreting these data. So these are some examples of nutrients that can be measured in the body fluids like blood or urine, and these can be influenced by diet. So we covered anthropometric data and biochemical data. The third dimension is clinical data. Clinical data can be like history and physical examination. So information such as a medical diagnosis, recent hospital admissions, the medications list, any changes in intake of food and fluids, food supply and preparation ability, weight changes, these are all falling under clinical data. Nutrition focused physical exam, NFPE, is also falls under clinical data. Nutrition focused physical exam is a systematic way of evaluating an individual from head to toe. By conducting NFP, we are uh, examining their physical appearance and function, and we can discover some signs and symptoms related to malnutrition, nutrient deficiencies, and toxicity. So we will see that later um, regarding nutrition focused physical exam. And you will see based on different signs and symptoms and based on the changes in an individual's appearance, we can detect malnutrition or nutrient deficiency or toxicity. And the last dimension of nutritional assessment is dietary data. So this is the data on food supply and nutrients consumed, and there are different ways of obtaining data and information from clients and patients and community for dietary data. including but not limited to dietary surveys, food diaries, 24 dietary recall, food frequency questionnaires, food habit questionnaires. But remember, the gold standard for determining nutrient information is the multiple week diet record. This is very important. That's why it is bolded. So this statement, this sentence is very important. The gold standard is is through multiple week diet record or food record. So food frequency questionnaire is a structured listing of individual foods. We mostly use food frequency questionnaire in research and in the community-based events like health fairs. 24 diet recall is also commonly used in research, and it measures the dietary intake in the previous 24 hours. And a food diary report all food and fluids consumed for a specified period of time. There are some limitations and drawbacks regarding these methods, and it is, these are all self-reported, and these rely on memory. So people, clients, patients can forget some foods or fluids they consumed in the past week or month or year or 24 hour. So based on that, there are some limitations regarding using these methods. But again, the gold standard is multiple week diet record. So nutrition assessment is part of the nutrition care process. Nutrition care process is a standardized model tool, and it is utilized by dietitians to improve the consistency and quality of individualized care for patients, clients, or groups. And nutrition assessment is the first step in the nutrition care process. Nutrition care process has four main steps: nutrition assessment, nutrition diagnosis, nutrition intervention, nutrition monitoring, and evaluation. So nutrition assessment is the first step. So nutrition care process, this is a kind of a standardized framework. And in the hospital and other clinical setting, dietitians, RDNs, they use nutrition care process because through nutrition care process, they uh, coordinate with other healthcare members in the hospital. It is a systematic approach to providing high quality nutrition care. So it's kind of ensure our audience that they are providing a high quality nutrition care to patients. They are all following the same framework. They are all following the same guidelines to provide nutrition care to people, to clients, to groups, to patients. So inside the nutrition care process, we have nutrition care process terminology, and this facilitates clear communication during the nutrition care process. Again, the reason why we use nutrition care process is that RDNs can coordinate with each other, can communicate with each other, and can communicate with other healthcare members in the hospital. And it contains the nutrition care process terminology contains more than 1,000 terms, and it is developed by researchers and practitioners. We use nutrition care process terms and terminology when we are uh, reading healthcare records, when we are trying to prescribe a diet or nutrition intervention, we all follow nutrition care process. So as I mentioned, it has four steps, and those steps are distinct but in and interdependent, but interrelated, intercorrelated with each other. And it is performed in this order: nutrition assessment, nutrition diagnosis, nutrition intervention, and nutrition monitoring and evaluation. So, for the nutrition assessment, we are asking this question: what fundamental nutrition problems are present? This is the first step. In nutrition diagnosis, we are trying to ask this question and try to find answer to this question actually. What specific medical conditions have these problems caused? And under nutrition diagnosis, we have the famous PES statement, which stands for problem, etiology, and signs and symptoms. And nutrition intervention, we are asking what changes should be put in place to address these issues. By nutrition intervention, we are trying to resolve the etiology of nutrition diagnosis. And the monitoring and evaluation, it's very similar to nutrition assessment, and it is kind of nutrition reassessment, but there are some differences, and we will see that. So this is a nutrition care process. As you can see, it is a circle, which means nutrition care process is not a linear process. It is a non-linear process in it, and it starts with nutrition assessment, then it goes back to nutrition reassessment, and then we start it again until the nutrition problem is resolved. After a nutrition problem is resolved, then we can close nutrition care process. We can discontinue this process. But again, the first step is nutrition assessment. And then we move on to nutrition diagnosis. Based on the nutrition assessment we had, we identify a problem. And then we determine etiology and causes to that problem. And then we record the signs and symptoms of that problem. Then we develop a nutrition intervention to address the etiology and causes of the nutrition problem. And after implementing the nutrition intervention, we need to monitor and evaluate our intervention. And if the problem persists, then we move to nutrition reassessment. Or if the problem changes and other problem emerges, we need to do nutrition reassessment. Here we have other factors, and there are some other terms that I would like you to pay attention to them. So look at the center of this circle, nutrition care process model. This is called the nutrition care process model. At the center, we have our clients, our patients, and the groups or society. And at the center, we have the interaction of dietitians and clients. And at the outer layer of this model, we have some terms and some phrases, and those are like some factors affecting the nutrition care process, such as code of ethics, documentation, critical thinking, evidence-based practice, communication, skills and competencies. And the outer layer is economics, social systems, healthcare systems, and practice settings. These are all influencing the nutrition care process. And this slide shows those external factors. I'm gonna move on. So the nutrition diagnosis, just like nutritional assessment and overall nutrition care process, has its own standardized language and terms. We use nutrition diagnosis to identify and define a particular nutrition problem that needs to be managed or cured or prevented, and etc. It is told nutrition diagnosis is different from medical diagnosis. Nutrition diagnosis can be resolved, but sometimes, and actually most of the time, medical diagnosis cannot be cured. But nutrition diagnosis can be cured and can be resolved. But my medical diagnosis cannot be. So let's see some examples. What do you think? Inadequate sodium intake is a nutrition diagnosis or medical diagnosis? How about congestive heart failure? So as you can see, an um, inadequate sodium intake is a nutrition diagnosis, and RDNs like dietitians can address this problem. But congestive heart failure is a medical diagnosis. It's totally out of our scope of practice, and it's not within the scope of dietitians and nutritionists practice. So that's nutrition, that's medical diagnosis. So again, the nutrition diagnosis is totally different from medical diagnosis. And nutrition diagnosis has three domains: intake, clinical, and behavioral. Intake is the most important dimension of nutrition diagnosis. So on the right side, we have a table and it shows the domains and the problems related to those domains. So regarding the intake domain, we have inadequate energy intake or malnutrition. That's a problem related to intake. Regarding clinical, impaired nutrient utilization or unintended weight loss is a clinical nutrition diagnosis. Regarding behavioral and environmental, not ready for diet or lifestyle change, or limited access to food or water. So these are behavioral or environmental domain for nutrition diagnosis. When we try to address nutrition diagnosis, we use the PES statement. Again, P stands for problem, E stands for etiology, and S stands for signs and symptoms. And look at that example on the right side of the slide. Uh, unintended weight loss, that's the problem, related to poor meal intake and loss of support for preparing meals. That's the etiology, as evidenced by a 13 pounds weight loss in 3 months. That's the signs and symptoms. So we connect PES components by related to phrase and as evidenced by phrase. So we are connecting problem to etiology by using related to, and we are connecting etiology to signs and symptoms by using the phrase as evidenced by. And the third step of the nutrition care process is nutrition intervention. And the main goal is to resolve the nutrition problem. And it is defined as the action taken by the nutrition and dietetics professional to correct or manage a nutrition problem. And again, we are trying to targeting the etiology of the nutrition diagnosis, and nutrition intervention must be individualized. It has two distinct steps: planning and implementation. So by planning, we are selecting and prioritizing the nutrition diagnosis. Sometimes some patients can have multiple nutrition diagnoses. So that's all. That's all up to the dietitians and RDNs to prioritize the nutrition problem and then develop and plan and implement nutrition intervention. So when we have multiple nutrition diagnoses, we need to select and prioritize the nutrition diagnosis. And it is the case for most patients. Um, in the planning step of nutrition intervention, we need to collaborate with other caregivers. We need to involve the patient and their representative, like their parents or their children. We need to review evidence-based practice guidelines and follow them. And the under the implementation step of nutrition intervention, we have communicating and carrying out the care plan, and those are individualized plan, and we need to monitor the plan for acceptance and effectiveness. The nutrition intervention has four domains. The first one is food and nutrient delivery. Can be enteral nutrition, parenteral nutrition, or provision of meals, snacks. Nutrition education is kind of a nutrition intervention. Nutrition counseling is also kind of a nutrition intervention, and the coordination of care, which means we are collaborating with other healthcare members to deliver nutrition intervention to patients and clients. And by nutrition education and counseling, we are trying to help the clients to make healthy food choices, to make some positive lifestyle changes. And the last step of the nutrition care process is monitoring and evaluation. So here we are examining the progress made by the individual in achieving the predetermined outcome. So after implementing the nutrition intervention, we need to monitor some data. We need to gather some data from individuals and patients to see how they are making progress toward our goals. So for regarding data sources for monitoring, we have self-monitoring information. So we can ask some questions and we can gather some self-reported data from clients. Again, we have some forms again we can use in this step, and then we can kind of compare the data obtained from clients, from patients, and compare them to standardized guidelines and to see where our individual is, whether they are on track or not. So there are, regarding monitoring and evaluation, there are three unique and interconnected steps. Again, these are distinct steps, but they are interconnected and intercorrelated with each other. We have monitoring process, and then we have measuring outcomes, and we have evaluating outcomes. So in the monitoring process, we are collecting and analyzing data, and then we measure outcomes. And for the evaluating outcomes, we are evaluating the change between the outcomes obtained at the end of the nutrition care process and compare it to the data we had at the beginning of the nutrition care process.